5. Vitamins that keeps oral and gum healthy. 2. Contents Introduction. History. Classification. Individual vitamins. Public health importance. Conclusion. 3. Intoduction. Vitamins have been defined as organic compounds which are required in minute amounts to maintain normal health of organisms. 4. A short history of vitamins O from about 1500 BC. It was known that various diseases could be treated with specific foods. In 1880 Christian Eichmann produced vitamin deficiency conditions in animals on an experimental basis and then reversed the condition with an appropriate feeding regimen. 5. Vitamins fat-soluble water-soluble B-complex. Non-B-complex vitamin A, vitamin D, vitamin E, vitamin K, thiamine, B1, riboflavin, B2, niacin, B3, pyridoxine, B6, biotin, B7, pantothenic acid, B5, energy-releasing hematopoitic folic acid, B9, vitamin B12, cyanocobalamin, vitamin C. 6. Vitamin A. Vitamin A is widely distributed in animal and plant foods. Animals preformed, retinol. Plants, proformed, carotene. 7. Vitamin A. Dietary sources of vitamin A7 preform vitamin A, meat, liver and dairy products. Proform vitamin A, yellow, red, and green vegetables and fruits. 8. Vitamin A. Recommended dietary allowance, men and women, 600 mcg per day. Pregnancy and lactation, 950 mcg per day. Infants, 350 mcg per day. Children, 600 mcg per day. 9. Vitamin A. Absorption and storage. The liver has enormous capacity to store, in the form of retinol palmitate. Under normal conditions a well-fed person has sufficient vitamin A reserves to meet his need for 6 to 9 months or more. Free retinol is highly active but toxic and therefore transported in bloodstream in combination with retinol binding protein, liver. 10. Vitamin A. Physiological functions of vitamin A: vision, epithelial cell integrity, reproduction, resistance to infectious disease, bone remodeling, growth. 11. Vision. 12. The signs of vitamin A deficiency: ocular night blindness, conjunctival xerosis, bitose spot, corneal xerosis, keratomalacia, extraocular retarded growth, skin disorders, effect on reproductive organs, effect on bone. 13. 14. Hypervitaminosis A. If the daily dose 30,000 mcg. Toxic symptoms: painful joint thickening of long bones, anorexia, low-grade fever, rashes, irregular menstruation, fatigue, loss of hair. 15. Oral manifestation of vitamin A deficiency: teeth. Vitamin A deficiency leads to defective formation of enamel, hypoplasia of teeth, since enamel-forming cells are disturbed. Dentin lacks the normal tubular structure. Caries: there is increased risk for caries eruption, delayed in prolonged deficiency. 16. Alveolar bone, retarded in its rate of formation. Gingiva, gingival epithelium becomes hyperplastic, in prolonged deficiency it shows keratinization. Periodontal disease, tissue is easily invaded by bacteria that may cause periodontal disease. Salivary gland, undergo typical keratinizing metaplasia. 17. Treatment: vitamin deficiency should be treated urgently. Depending upon deficiency symptoms, it is given in the dose of 7,500 to 15,000 mcg per day for 1 month. Nearly all of the early stages of xerophthalmia can be reversed by administration of a massive dose, 2,00000 IU or 110 mg orally on 2 successive days. if hypervitaminosis restriction of diet. 18. Prevalence World Bank, 2007, Prevalence of Vitamin A Deficiency, VAD, Prevalence of clinical and subclinical vitamin A deficiency in India is among the highest in the world. Though prevalence of clinical vitamin A deficiency is less than 1% in India, biochemical subclinical deficiency is quite high. 19. Massive dose vitamin A program in India. The National Prophylaxis Program Against Nutritional Blindness Due to Vitamin A Deficiency, NPPNB, was initiated in 1970 with the specific aim of preventing nutritional blindness due to Keratomalacia. 20. In 1994, under the National Child Survival and Safe Motherhood, CSSM, program, the NPPNB due to VAD was modified, keeping in view of the vulnerability of VA deficiency in young children. The age group of eligible children for coverage was restricted to 9 to 36 months of age in 2006. The age group of eligible children was revised as 6 to 59 months. This was done after reconsidering the recommendations of WHO, UNICEF and Ministry of Women and Child Development. 21. Vitamin D. It is also called sunshine vitamin. It is available in two forms: D3, cholecalciferol, D2, calciferol. 22-24 Dietary sources of vitamin D. Good sources of vitamin D include fatty fish, fish liver oils, egg yolk, etc. In a natural way, exposure of skin to sunlight synthesizes vitamin D. 23-25 Chemical origins of vitamin D. Precursors of vitamin D are found in both yeast and animal tissues. In yeast, a sterol precursor, ergosterol, is converted to vitamin D2, ergocalciferol. Ergocalciferol is the compound most commonly found as the additive to fortify milk. In the dermal tissue of animals, the precursor is 7-dehydrocholesterol, which is converted first to a pre-vitamin D3, then to vitamin D3, cholecalciferol. Vitamin D2 and vitamin D3 are both converted to similar active compounds, calcidiol and calcitriol, in the liver and kidney. D2 and D3 are sometimes referred to as vitamins. 24-26 Recommended dietary allowance of vitamin D. The daily requirement of vitamin D is 400 international units of cholecalciferol. In countries with good sunlight, like India, RDA for vitamin D is 200 international units per day. 25-27 Absorption and storage of vitamin D. This depends upon the source of the vitamin D. Vitamin D that is taken into the gut, vitamin D containing foods or nutritional supplements, are absorbed by intestinal mucosal cells in the duodenum and jejunum and packaged into lipoproteins called chylomicrons, cm. The cm carry the vitamin to the liver or adipose for storage and eventual use. Vitamin D synthesized in skin through the action of sunlight is bound to a blood protein called vitamin D binding protein, DBP, which transports it to the liver. 26 Liver skin blood 7-dehydrocholesterol inactive compounds provitamin D3 D3, cholecalciferol, DBP, VIT. D binding protein, DBP D3 24, 25-OD3, inactive, 1, 25-OD3, active, calcitriol, kidney Ca++ transport, intestine, Ca++ resorption, bone, D3, calcidiol, 25-OD3 25-OD3 DBP calcidiol, tight binding. 27. Biochemical functions of vitamin D. It regulates the plasma levels of calcium and phosphate. Calcitriol acts at 3 different levels to maintain plasma calcium: normal 9-11 mg/dl, action of calcitriol on intestine, action of calcitriol on bone, action of calcitriol on kidney. 28-30 Vitamin D. deficiency rickets children's osteomalacia adults increase the risk of osteoporosis. 2931 Rickets. The term is derived from the Old English word for twist, or rick. Rickets is caused by a deficiency in vitamin D. During growth, human bone is made and maintained by the interaction of calcium, phosphorus, and vitamin D. Calcium is deposited in immature bone, osteoid, in a process called calcification, which transforms immature bone into its mature and familiar form. 30. Osteomalacia. It is also known as adult rickets, and flat bones and diaphysis of long bones are affected. It is most commonly seen in post-menopause female with history of low dietary calcium intake. The majority of patients have bone pain and muscle weakness. 32. 3133 Vitamind. Oral manifestation: teeth, developmental abnormalities of dentine and enamel. Caries, higher risk of caries. Enamel, there may be hypoplasia of enamel, may be mottled, yellow-gray in color. Pulp, high pulp horns, large pulp chamber, delayed closure of root apices. 3234 Management. Dietary enrichment of vitamin D in the form of milk. Curative treatment includes 2000 to 4000 IU of calcium daily for 6 to 12 weeks. Patient with osteomalacia due to intestinal malabsorption require larger dose of vitamin D and calcium, i.e. 40,000 to 1,00,000 IU of vitamin D and 15 to 20 gms of calcium lactate. 33. Prevalence. Vitamin D status of ostensibly healthy Indians. Countrywide studies, 2014, have reported vitamin D deficiency in as high as 70%, 100% of ostensibly healthy individuals. All over India, vitamin D deficiency was highly prevalent in pregnant women and lactating mothers. Subjects from rural and urban areas presented a similar picture. Evidently, countrywide prevalence of vitamin D deficiency is undeniable. 34. Vitamin D supplements available in India. Supplements commonly available are D3, cholecalciferol, 1,25, O, 2D3 and 1-alpha-hydroxyvitamin D3, alpha-calcidol. Some formulations have calcium too. Multivitamin formulations are also available and contain about 400 IU of D3. D3 supplement of 60,000 IU is the highest selling one. 35. Need for vitamin D. Fortified food products in India. Vitamin D sufficiency via sun exposure is untenable for most Indians. Most Indians are vegetarians. Fortification of widely consumed staple foods with vitamin D is the only viable solution towards attaining vitamin D deficiency in India. Unlike supplementation strategies, fortification of food with vitamin D poses a negligible risk of toxicity. 36. Vitamin E. Vitamin E is a naturally occurring antioxidant. It is essential for normal reproduction in many animals, hence known as anti-sterility vitamin. 37. Dietary sources of vitamin E. Many vegetable oils are rich sources of vitamin E. Wheat germ oil, cottonseed oil, peanut oil, corn oil, sunflower oil. It also present in meat, milk, butter, and eggs. 38. Recommended dietary allowance of vitamin E. A daily consumption of for men 10 mg, for women 8 mg. Vitamin E supplemented diet is advised for pregnant and lactating women. 39. Biochemical functions of vitamin E. Vitamin E is essential for the membrane structure and integrity of the cell, hence it is regarded as membrane antioxidant. It prevents the peroxidation of polyunsaturated fatty acids in various tissues and membranes. It protects RBC from hemolysis by oxidizing agents. It preserves and maintains germinal epithelium of gonads for proper reproductive function and prevents sterility. It protects liver from being damaged by toxic compounds such as carbon tetrachloride. It works in association with vitamins A, C and beta-carotene, to delay the onset of cataract. It is believed that it prevents the oxidation of LDL, which have been implicated to promote heart diseases. 40. Deficiency of vitamin E, sterility, degenerative changes in muscle, megaloblastic anemia, changes in central nervous system, oral manifestations, loss of pigmentation, atrophic degenerative changes in enamel. 41. Vitamin K. It is available in two forms. K1, it is the form occurs in plant origin. K2, is synthesized by intestinal bacteria. 42-44 Dietary sources of vitamin K: spinach, cabbage, cauliflower, soybean, wheat germ, carrots, potatoes, tomatoes, milk, meat, fish. 43. Recommended dietary allowance of vitamin K: men and women, 70 to 140 mcg per day, children, 35 to 75 mcg per day. 44. Biochemical functions of vitamin K. It is essential for the hepatic synthesis of coagulation factor 2, V, 7, 9, X. Clotting, it prevents hemorrhage only in cases when there is defective production of prothrombin. Oxidative phosphorylation, it acts as a cofactor in oxidative phosphorylation associated with lipid. 45-47 Deficiency of vitamin K causes increased clotting time, prolonged bleeding, hemorrhagic conditions after antibacterial therapy, surgical operations, cholecystectomy, conditions like malabsorption, obstructive jaundice. 46. Vitamin C. It is also called ascorbic acid and antibiotic vitamin. It is the most active reducing agent. It is powerful antioxidant. 47. Dietary sources of vitamin C: citrus fruits, gooseberry, guava, green vegetables, tomatoes, potatoes are rich in ascorbic acid. High content of vitamin C is found in adrenal gland and gonads. Milk is poor source of ascorbic acid. 48. Recommended daily allowance of vitamin C: adults, 60 to 70 mg per day. Additional intake, 20 to 40% increase, are recommended for women during pregnancy and lactation. Biosynthesis and metabolism of vitamin C: men cannot synthesize ascorbic acid due to the deficiency of single enzyme, namely L-guanolactone oxidase. 49. Biochemical functions of vitamin C: 1. Collagen formation, 2. Bone formation, 3. Iron and hemoglobin metabolism, 4. Tryptophan metabolism, 5. Tyrosine metabolism, 6. Folic acid metabolism, 7. Synthesis of corticosteroid hormones, 8. Sparing action of other vitamins, 9. Immunological function, 10. Preventive action on chronic diseases. 50. Vitamin C deficiency: scurvy. This disease is characterized by spongy and sore gums, loose teeth, anemia, swollen joints, decreased immunocompetence, delayed wound healing, hemorrhage, osteoporosis. 51-53 Vitamin. Oral manifestations: scorbutic gingivitis, characterized by ulcerative gingivitis, rapid periodontal pocket development, tooth exfoliation. 52. Prevalence: Ravindran R.D. et al., 2011. The age, sex, and season standardized prevalence of vitamin C deficiency was 73.9 in 2668 people in North India and 45.7% in 2970 from South India. Only 10.8% in the North and 25.9% in the South met the criteria for adequate levels. Vitamin C deficiency was more prevalent in men, with increasing age, users of tobacco, poor nutrition, and with lower intakes of dietary vitamin C. 53. B-complex vitamins. Most B-complex occurs in nature in the bound form within the cells of vegetables or animal tissues. The digestion for the liberation of vitamins and its absorption is a result of breakdown of cellular structures in the gut. Excretion of vitamins occurs in the kidney. 54. Thiamine, Vit B1, it is also called anti-beriberi factor, antineuritic factor, and also anurin. It has a specific coenzyme, thiamine pyrophosphate, TTP, which is mostly associated with carbohydrate metabolism. It is colorless basic organic compound composed of a sulfated pyrimidine ring. 55-57 Dietary source of thiamine: cereals, pulses, oil seeds, nuts, yeast. Polishing of rice removes about 80% of thiamine. Animal, pork, liver, heart, kidney, milk. 56-58 Recommended dietary allowance of vitamin B1: men, 1.3 mg per day; women, 1 mg per day; pregnancy and lactation 2 mg per day; children, 1.1 mg per day. 57. Biochemical functions of vitamin B1: the coenzyme, thiamine pyrophosphate, or co-carboxylase, is intimately connected with the energy-releasing reactions in the carbohydrate metabolism. TPP plays an important role in the transmission of nerve impulse. It is believed that TPP is required for acetylcholine synthesis and the ion translocation of neural tissue. 58-60 Deficiency of vitamin B1: nervous disorders. When cells cannot metabolize glucose, it affects the nervous system first, since it depends entirely on glucose for its energy requirement. And there is mental depression. Digestive symptoms: it occurs due to defective hydrochloric acid production in the stomach. Patient complains of loss of appetite, poor digestion, loss of weight. 59. Deficiency of vitamin B1: beriberi A, dry beriberi B, wet beriberi C, infantile beriberi. Other diseases which can be associated with it are Wernicke's encephalopathy, peripheral neuritis, Korsakoff psychosis. 60-62 Vitamin B1 management: complete rest. Thiamine 50 mg IM for 3 days, then 10 mg 3 times daily by oral route. Infantile beriberi is treated via mother's milk. The mother should receive 10,000 mcg twice daily. In addition, infant should be given thiamine in doses of 10,000 to 20,000 mcg IM once in a day for 3 days. 61. Vitamin B1 oral manifestations: there is hypersensitivity of oral mucosa, pain in tongue, teeth, jaw, and face. Thiamine antagonists, pyrithiamine and oxythiamine, are the two important antimetabolites of thiamine. 62. Riboflavin, Vit B2. Riboflavin through its coenzymes takes part in a variety of cellular oxidation reduction reactions. Coenzymes of riboflavin: flavin mononucleotide, FMN, and flavin adenine dinucleotide, FAD, are the two coenzyme forms of riboflavin. 63. Dietary sources of vitamin B2: milk and milk products, meat, eggs, liver, kidney are rich sources. Cereals, fruits, vegetables, and fish are moderate sources. 64. Recommended dietary allowance of vitamin B2: adults, 1.2 to 1.7 mg/day; higher intakes, 0.2 to 0.5 mg/day, are advised for pregnant and lactating women. 65. Biochemical functions of vitamin B2: the flavin coenzymes participate in many redox reactions responsible for energy production. The coenzymes, FAD and FMN, are associated with several enzymes involved in carbohydrate, lipid, protein, and purine metabolism. 66-68 Chylosis: chapping and fissuring of lips, glossitis, inflamed red beefy tongue. Deficiency of vitamin B2. 67. Niacin, Vit B3. Niacin or nicotinic acid is also known as pellagropreventive, P.P, factor of Goldberg. The coenzymes of niacin, NAD and NADP, can be synthesized by the essential amino acid, tryptophan. 68. Dietary sources of niacin: rich natural sauces, liver, yeast, whole grain cereals, pulses, moderate sources, milk, fish, eggs, vegetables. 69. Recommended dietary allowance of niacin: adults, 15 to 20 mg/day; children, 10 to 15 mg/day. 1 mg niacin equals 60 mg tryptophan. 70. Biochemical functions of niacin: the coenzymes NAD and NADP are involved in a variety of oxidation-reduction reactions. A large number of enzymes belonging to the class oxidoreductases are dependent on NAD or NADP. 71-73 Deficiency of niacin: its deficiency results in pellagra. It is called disease of 3DS: dermatitis, diarrhea, dementia. Skin: in acute cases, skin lesions may produce vesiculation, cracking, exudation, crusting with ulceration and secondary infection. Chronic cases, dermatitis occurs as roughening and thickening of skin. If not treated, may rarely lead to 4th D, death. 72-74 Vitamin B3. Oral manifestation: oral mucosa becomes fiery red and painful, and salivation is profuse. Tongue: epithelium of entire tongue is desquamated. The tongue becomes red, swollen and beefy. In advanced cases, the tongue loses all the papillae and reddening becomes intense. 73 Pyridoxine, Vit B6. Vitamin B6 is used to collectively represent the three compounds, namely pyridoxine, pyridoxal and pyridoxamine. 74-76 Dietary sources of vitamin B6: vegetable sources, wheat, corn, cabbage, tubers, animal sources, egg yolk, fish, milk, meat. 75. Recommended dietary allowance of vitamin B6: adults, 2.2 mg/day; during pregnancy, lactation and old age, an intake of 2.5 mg/day. Recommended isoniazide, deoxypyridoxine and methoxypyridoxine are the antagonists of vitamin B6. 76. Biochemical functions of pyridoxine: pyridoxal phosphate, the coenzyme of vitamin B6, is found attached to the E-amino group of lysine in the enzyme. Pyridoxal phosphate participates in reactions like transamination, decarboxylation, deamination, transsulfuration, condensation. 77. Deficiency of vitamin B6: neurological symptoms such as depression, irritability, nervousness, and mental confusion, convulsions, and peripheral neuropathy are observed in severe deficiency. These symptoms are related to the decreased synthesis of biogenic amines, GABA, serotonin, epinephrine, norepinephrine, demyelination of neurons. 78. Biotin, Vit B7, biotin, formerly known as anti-egg white injury factor, vitamin B7 or vitamin H, is a sulfur-containing B-complex vitamin. It directly participates as a coenzyme in the carboxylation reactions. 79. Dietary sources of biotin: the rich sources are liver, kidney, egg yolk, milk, tomatoes, grains. 80. Recommended dietary allowance of biotin: men, women, 100-300 mg/day; children, 50 to 200 mg/day; infant, 35 mg/day. 81. Biochemical functions of biotin: biotin serves as a carrier of CO2 in carboxylation reactions. As a coenzyme, biotin is involved in various metabolic reactions: gluconeogenesis and citric acid cycle, fatty acid synthesis. 82. Deficiency of biotin: anemia, loss of appetite, nausea, dermatitis, glossitis. Biotin deficiency is uncommon as it is well distributed in foods and also supplied by the intestinal bacteria. 83. Pantothenic acid, Vit B5, pantothenic acid, Greek, pantos, everywhere, formerly known as chick anti-dermatitis factor. Its metabolic role as coenzyme A is also widespread. Recommended dietary allowance of Vit B5: adults, 5 to 10 milligrams. 84. Dietary sources of pantothenic acid. It is one of the most widely distributed vitamins found in plants and animals. The rich sources are egg, liver, meat, yeast, milk. 85. Biochemical functions of Vit B5. The function of pantothenic acid are exerted through coenzyme A or CoA, A for acetylation. Coenzyme A serves as a carrier of activated acetyl or acyl groups. This is comparable with ADP, which is a carrier of activated phosphoryl groups. 86. Deficiency of Vit B5. Burning feet syndrome, pain and numbness in toes, sleeplessness, fatigue. 87. Folic acid, Vit B9, folic acid or folicin, Latin, folium leaf, is abundantly found in green leafy vegetables. It is required for synthesis of certain amino acids, purines, and pyrimidine thiamine. 88. Dietary sources of Vit B9. Rich sources are green leafy vegetables, whole grains, cereals, liver, kidney, yeast, and eggs. Milk is rather a poor source of folic acid. 89. Recommended dietary allowance of folic acid. Adults, 200 mg. Higher intakes are recommended during pregnancy and lactation, 400 mg. 90. Biochemical functions of folic acid. Tetrahydrofolate, the coenzyme of folic acid, is actively involved in the 1-carbon metabolism. Aminopterin and methopterin are structural analogues of folic acid. They competitively inhibit dihydrofolate reductase and block formation of THF. Amintorin and methotrexate are used in treatment of many cancers. 91. Deficiency of folic acid. Macrocytic anemia. Folic acid deficiency in pregnant women may cause neural defects in the fetus. Hence, high doses of folic acid are recommended during pregnancy to prevent birth defects. Formiminoglutamate, Figlu, in urine is used to assess folic acid deficiency. 92. Cyanocobalamin, Vit B12. Most of the therapeutic preparations contain cyanocobalamin. It is sensitive to light. It is heat liable. 93. Dietary sources of Vit B12. It is mainly present in animal sources. Liver, kidney, brain, meat, fish, and eggs are good sources. Milk and milk products are fair sources. Curd is better source than milk. Since it is absent in plant foods, vegetarians are likely to develop Vit B12 deficiency. 94. Recommended dietary allowance of Vit B12. Adults, 3 mg per day. Children, 0.5 to 1.5 mg per day. During pregnancy and lactation, 4 mg per day. 95. Biochemical functions of Vit B12. Vitamin B12 acts as the prosthetic group or coenzyme. Vitamin B12 enzymes are called cobamide enzymes. About 10 enzymes requiring Vit B12 have been identified, most of them are found in bacteria. Synthesis of methionine from homocysteine. Isomerization of methylmalonyl-CoA. 96. Deficiency of Vit B12. Pernicious anemia. It is characterized by low hemoglobin levels, decreased number of erythrocytes and neurological manifestations. The excretion of methylmalonic acid in urine and estimation of serum B12 level are used to assess B12 deficiency. 97. Vitamin B12. Oral manifestations. Vitamin B deficiencies are one of the most common deficiencies that can affect your teeth and your mouth. Common oral effects of vitamin B deficiency are burning sensations in the mouth and on the tongue, trouble swallowing, swollen tongue, and pale tissues in the inner cheeks that could break apart easily and come off. 98. Prevalence. Bhavna Singh et al., 2011. A total of 422 patients screened for serum vitamin B12 levels were enrolled. B12 deficiency was observed in 19.4% men and 23.7% women in the present study, suggesting that risk of developing B12 deficiency is affected by gender among the vegetarian group. 59 out of 107, 55%, had vitamin B12 level less than 200 pg/ml, whereas only 16 of 77 non-vegetarians, 20.8%, had B12 deficiency. Vegetarian dietary habit was found to be a substantial risk factor for B12 deficiency in our population. 99. Public health importance. Vitamin deficiency conditions are widespread among people in developing and in developed countries. This silent epidemic affects people of all genders and ages, as well as certain risk groups. They not only cause specific diseases, but they act as exacerbating factors in infectious and chronic diseases, greatly impacting morbidity, mortality, and quality of life. 100. Most effective way to meet community health needs safely is by population-based approaches involving food fortification. These complementary methods, along with food security, education, and monitoring, are challenges for public health and for clinical medicine. 101. Understanding the pathophysiology and epidemiology of vitamin deficiencies, and implementing successful methods of prevention, both play a key part in the new public health. 102. Conclusion. Living a healthy life means making sure that your body is receiving all the proper vitamins and minerals it needs to function correctly. It's also important to make sure that you're maintaining a healthy mouth, since that poor oral health may be a link to certain health issues, including heart disease, obesity, stroke, and even cancer. A daily multivitamin is a great nutrition insurance policy. Some extra vitamin D may add an extra health boost.